of the time when you're looking at, you're getting questions on the rectum and anal canal, it's on a sagittal section, right? Because you can't see much on the looking into the abdomen. But I have one specimen here, which is a small cadaver that I use because a camera can follow it easily, right? Okay. Or camera, we have a bit of a problem with the camera today. It jumps a little, so I'm going to try and manipulate the specimen so you can see, right, what I want to see, right? So I'm starting now here with just showing you some things that are in this cadaver. So right here, right, we have the abdominal aorta, right, okay? And here we have the right common iliac artery, the left common iliac artery. Anybody can tell me what point does that abdominal aorta bifurcate into the right and left common iliac artery? And this question goes to Madison. Madison, can you tell me what vertebral level that is? Shania Quintalia. I know Shania answers all my questions. I'm a Socrative, so. Shania, what level does the abdominal aorta bifurcate into the right common iliac and the left common iliac artery? L4. Very good, right? L4. And what level now does this left common iliac vein here, right? Sort of gone and went into it a little bit there, but there it is, right? Anteriorly, left common iliac vein and right common iliac vein, right? Okay. What point would it form the inferior vena cava? It goes back to Ariel. Ariel, you answered a while ago by chat, so you can continue to chat with me. All right. What level is that? If this is at L4, what level do you think that would be? Ariel. L5, very good. By now, you shouldn't have 5 question marks behind that. You should just answer me right away, right? Okay? Right? That's what I want. And you have to know the levels for L4, right? Okay? And the levels for L5. L4 is difficult because you can't really see it on the front here. You have to go right up to the superior part of the iliac crest, right here, right? Okay, right? That's called the supercrystal plane, which when you extrapolate, supercrystal planes up here, the supercrystal plane, right? Okay, right. So that if you come there now, that's L4, right? This one's L5. Now, why it's important to know that plane, that's the highest part of the iliac crest there, right? Is that if you're an anesthetist, right, and you're going to give a spinal anesthetic, right, okay, you want to know where the spinous process of what spinous process coincides with that point. We put the patient seated like this and you feel for that plane like that, and then you can see that that's L4, right? So you really can't miss. You have to go above L4, you go below L4. Those are the favorite sites to give a spinal anesthetic, right? Okay, so you have to know that. That's the supercrystal plane. That's above the crest, so supercrystal, right? Okay, crest and crystal is the same thing, right? Okay, right? L4. Now this is L5, and that's where the inferior vena cava is going to form. Right now, the plane you need for that is a plane that runs between. This is the anterior superior iliac spine here, and this is the iliac tubercle. Right, okay? Tubercle of the iliac. Right, okay? So what's the name of that plane that runs from here to this one? Ariel, you stay on the ball still? That would be the intertubercular or transtubercular. Intertubercular is the best one, okay? And it goes to L5. So those questions are going to come. Although posterior abdominal wall, you really get more when you do GU, right? So that's the next semester. But I'm giving you a little preps on it, right? Okay? All right. So when the abdominal aorta node, and if we look up here, we'll see it has three midline arteries. This one is the celiac trunk, and this is the superior mesenteric artery. And I said, but wait, it looks like one artery. Well, this is supposed to come off at T12, right? That's celiac trunk. And the superior mesenteric artery was to come off at L1. Sometimes they're pretty closer than that, right? And they actually come off sometimes just right next to each other. Not very often, but on this cadaver, it does. So, right, okay? So we come down now and we see the third artery here now. I know Dr. Ludenke went through this with you yesterday, right? Okay, so what's this third artery? Everybody should know this one. What's the name? Shania, what's the name of this artery? Superior mesenteric, celiac, superior mesenteric, and this one is the inferior mesenteric, right? Okay, very good. Okay, so what vertebral level is that now? Anybody? That one you have to know. What vertebral level is that? So 5, 4, 3, L3. All right, okay. So we don't have 5, 4, 3, 2. We don't have 2 and 1. So 2 is not for any one of these arteries. 1 is for the superior mesenteric, and T12 if it was on this specimen. But I like these small specimens. I can walk around with them, and I don't have to total on a big skeleton. You understand me? This is a male skeleton. Everybody should be able to recognize that. That's the way a baby can go through that lumen there. You can see it's heart-shaped because it has a prominent sacral promontory. And you can see the subpubic angle here. You can just take between my index finger and the middle finger. If it's a female now, the subpubic angle would be wide like that. The baby has to go through it, see? So this is an android pelvis, all right, okay? And I'm going to come back to it in a little while when I'm showing you where the rectum starts. You must wonder what I'm talking about today. I'm not getting those. Okay, so we look here now. This is inferior mesenteric artery. So my dissection here, right, okay? Right? Inferior mesenteric artery. The Gardner's lecturer would have told you it gives off a left colic branch, right? And then, you know, he always says that then we have the rectosigmoid branch, like that. But I never really see it like that because as soon as it gives off a left colic branch, it starts giving off the sigmoid branches. So like 3 sigmoid branches there. When you come here now, right? Okay, you can tell me what is that now? The sigmoid arteries are gone already. What artery is that? Demoid lindo. Come demoid. Answer quick. What artery is this? What about Donnie Johnson? You haven't answered anything as it, Donnie. What artery is it? No. After the inferior mesenteric gives off the left colic branch. This is the semicolon here, right? And this is the sigmoid mesentery we're looking at here. Sigmoid mesentery is like a V-shaped mesentery like that, right? Okay, you have one limb going down here, and Mr. Dr. Ludenke told you that yesterday, and the other a medial limb and a lateral limb, but I've dissected off the whole thing, right? Okay, right? Okay. So what is this artery? Going over the pelvic rim now, in front of the left common iliac artery. Who can tell me the name of this artery? Superior rectal artery. Very good, Sydney. Excellent, right? Okay. Excellent. It's the main arterial supply of the rectum. The branches go all the way down to the inner rectal junction. All right, okay? Right? So you have to know it goes in front of the left common iliac artery and it goes down the brim down behind the sigmoid colon, and then it's going to get down to the end of the sigmoid. All right, okay? So this left colic artery, we're going to have an ascending branch, descending branch, and they all get together and form an artery that's continuous right around the colon. What's the name of that artery? That connects up all these branches going right around. Who can tell me the name of that artery? all these branches, sigmoid branches, colic branches, middle colic, the ileocolic, right colic, ileocolic. Marginal artery, very good, John Guy. Marginal artery of who? Of Drummond, Drummond. Drummond, very good, very good. You guys on the board. All right, okay. So this is the sigmoid colon that Akula would have told you a lot about. So here we can see the things that are pathognomonic of the colon. Anybody can tell me what this is? What are these little things popping off here, of the colon? Demoid. What are these little things? Look like an appendix, eh? An appendage. What is it? Appendices epiploidy. So when the appendices epiploidy start disappearing now, and we can, oh well, we can. Good. The appendices epiploidy start disappearing, right? Here we come into the rectum. You can tell me how long is the rectum. So and then the other thing you see on the colon is this longitudinal band we see in here. What is that? The tinea coli, right? So the tinea coli goes, right, again, the appendices of the fluid goes, the hostrations go, right, because you can see some hostrations here, not much down here, okay? But then we come now to the rectum, right, again? So how long is the rectum? How long is the rectum? 12 centimeters, very good amount, okay? So what percentage of it has totally, what length of it totally has peritoneum right around it? The upper 4 centimeters. Okay, we'll divide it into thirds, right? Okay, 4 centimeters. And then as we get down in here now, you can sort of get an idea that we see, and it's always hard to show you this, right? Okay, right? We get an idea now that we're seeing part of the colon here. You may not agree with it, sort of dissected off the peritoneum here from the pelvic wall, and the peritoneum just seems to be on the anterior aspect, not right around it like this side here. As we get down here, it's an anterior aspect, right? Okay, right. So what part of that now? What part is that? That's the middle third, right? Okay. Then we have, anybody can tell me what this organ is, right? This is a male. But you can see that there, okay? All right? So, what organ is this we're looking at? So this is the bladder, right? Okay? And here is what pouch? What's the name of the pouch here? And the male, what's the name of the pouch? The rectovesical pouch. All right, okay? Right, now, Dr. Denker showed you all this yesterday. But here's, you can see when as a surgeon, I go in and I don't do much surgery again. I've done lots of this in my lifetime, but I take a break now. I get old, yeah? So, trying to stay, trying to stay alive in all this madness that's going on there. All right, so here is the sigmoid mesocolon. So I have to dissect this off because sometimes I go into a tumor right here. I have to take away this sigmoid tumor. I have to dissect the sigmoid and reflect it before I can resect it. You see. So when I'm doing that, taking it off, what is this structure coming up here? Right, that I have to watch out for. Yeah? What is it? Going right up to here. What is that? Somebody saying something? Anybody can tell me? That's left ureter. Sometimes I forget what I'm teaching. I'm really not teaching you G right now, but you have to know that the left ureter is an important relation of the sigmoid mesocolon. All right, okay? All right, now let me see if I can show you the inferior mesenteric vein that runs between the superior mesenteric artery here. All right, okay? Here it is. Right, here it is. Inferior mesenteric vein, right, okay? Coming up, right? Between the ureter here and the superior artery. All right, okay. So where does that inferior mesenteric vein going to go? Anybody knows where it drains? But you don't, it drains up into the splenic vein. Right? You should know that because that is, you did that when you did, well, no, you haven't done liver yet. Okay, all right, okay, fine. All right, so that is inferior mesenteric vein. That drains the rectum. All right, so it's a good point now to get rid of this big boy here and come down to the meat of the matter. The meat of the matter is a sagittal section. So, you see why I like these small things? I can lift them myself. You Mr. Cooper and watch it. Right? Mr. Cooper would like to know that. Using alveoli of his skull. Show the specimen like this. Right? So we come now, right? Okay. What are going to put you there? Very good, very good. All right. Where's my mark? Okay, sorry. All right. So here is the sigmoid. We can see, right? Okay. We have a sagittal section now, a male, right? Okay, because again, you can see there's no uterus anywhere. I'm going to show you a female in a while. So you can see that the sigmoid, which has appendices epiploidy, you can just see a tinea right here, now becomes, right, okay, it's going to become the rectum down here. We start seeing the transverse rectal folds, right, okay, one here, right, okay. So, second 4 centimeters is going to be this, what we're seeing right here, behind the bladder, right, okay, and what is, right, okay, and this is the pouch we were looking at a while ago, the rectum is like a pouch. All right, okay. So the rectum is 8 centimeters long, and then it has 2 major curvatures. You can see this one right here, right? Everybody can see this one. What curvature is this? No, sacral. Who's that? Sydney. Sydney's on the ball today. Brianna, that could not be the perineum. All right, okay, we're not nowhere near the hypostasis. All right, I'll show you the perineum, I don't know why. The first one I'm asking you, there's the sacrum, right, okay? So it's a good point to show you that this pelvis, because here's the sacrum, 5 pieces of 5 sacral vertebrae fused together. They have 1 and 2. Hard to see them sometimes. 3 is about here. Right, okay, so what big right here? Right? So we have 1, 2, 1, 2, 3. What big event happens right here at S3? Raquel Brown? What transition happens in front of S3? Sigmoid mesocolon ends. That's where the medial part, remember the sigmoid mesocolon is triangular in shape, and the medial limb of it, right? Medial limb of it. Prevention.
You want to use that too?
Yeah, I won't mind. I can just throw it if we look here, right? That's it. So here is a sacrum, and this is S1, S2, S3. So we have 2 limbs to this sigmoid mesocolon. There's the medial limb, there's the lateral limb. The lateral limb goes more towards the source. Right, okay? Right, okay, so the medial limb ends there, and that's the end of the sigmoid colon, and the rectum, the rectum starts. All right, okay? Then the rectum is going to run right down to, anybody can tell me where the sigmoid colon ends? All right, so here we have the sacrum, and here's the coccyx, broken away a little bit of the tailbone. Right, okay, broken away there. All right, anybody can tell me? The rectum, 12 centimeters long, and where does it end? Then is the perineal flexure, and what is the surface market for the perineal flexure? The sigma, not sigma, the rectum ends, sorry. Rectum ends, and the anal canal starts. It ends just below, 2 to 3 centimeters in front, and just below, not just in front, and just below, and 2 to 3 centimeters in front. So right about here, right? Okay, that's where they are. The rectum is going to end, and the anal canal is going to start. I'm going to show you that. Now, before I go, I'm going to get rid of the specimen now. I'm going to show you that, and I'm certain someone has gone through the pelvic diaphragm with you. I'm going to go over it with you again tomorrow morning because we have to talk about the ischial fossa. And the pelvic diaphragm separates the pelvic cavity from the perineum. So this area, when we look here, we see the perineum. Right, okay? So this area here, the perineum is going to be here. So the bony landmass of the perineum, everybody should remember that anteriorly is the pubic symphysis, and posteriorly the tip of the coccyx. Laterally, the ischial tuberosities. The anterior lateral wall is the ischial pubic ramus, and the posterior lateral wall, right, is a sacral tuberous ligament coming from here to here. Sacral tuberous ligament. Right, okay? That's the perineum. All right? And that perineum is going to be divided into a urogenital triangle anteriorly, and posteriorly here, right, anal triangle. Right, okay? And in that anal triangle, you can find the anal canal. Right, okay? And the ischial fossa. And the pudendal canal, which I have dissected out to show you today. All right? So, let's go on now with the rectum. All right? The rectum is 12 centimeters long, right? And it has 2 curves. So this first curve is a sacral curve here. And the second curve now, we look, right? Right? We now, you can see that this sacral curve ends, and when it gets to that level, tip of the coccyx, well, you really can't just about feel it here, right? Tip of the coccyx. Because there's S1, S2, S3, S4, S5, coccyx would be right here. Right about there, that's the perineal flexure. So you can see the rectum that curves like that now goes through almost a 90 degree, not quite 90, but 80 degrees, okay? Right? So the rectum, the anal canal, this is anal canal down here. The last 4 centimeters, gastrointestinal tract. And we can see some of the things that I told you about in the lecture yesterday. There we can start seeing the columns of Malgagni and all that right there. Right, okay, so I'm going to be showing you that. But we're going to talk about the rectum first, right, okay? Now, the other thing with the rectum is that what happens to the tinea coli? Anybody can tell me? Tinea coli now becomes a continuous layer outer longitudinal muscle. Right, so you have mucosa, submucosa, muscularis externa, which is the circular internal muscle and the outer longitudinal muscle. Right, okay? And then most of the rectum, as you can see, is actually extraperitoneal. So here, the peritoneum, right? Let's see. Yeah. Okay, so the peritoneum of the peritoneum at the superior surface of the bladder, right? Then the peritoneum at the anterior surface of the third part of the rectum, right? Okay, that's the rectovesical pouch, right? Okay, so we can see that most of the rectum is extraperitoneal, just like the bladder, right? The only part of the bladder that has peritoneum on it is the superior wall, right? Okay, this one, right? Okay, superior wall. All right. Now, that's a very important point because I spent 30 years at KPH doing emergency surgery, and people would come in, right, with a stab wound. They come in with a stab wound to abdomen. The damage is bowel. The casualty officer picks it up easily, right? Okay, because the patient has peritonitis. right? So the abdomen, stab wound or gunshot wound, 2 minute dose in my lifetime, right? Okay, right? And they call the surgeon, so they go in and open the abdomen, fix what's wrong. But sometimes, many times, the patient gets stabbed in his bum or a gunshot wound in his buttock sometimes. So the doctor examines the abdomen, right? Okay, surface the patient is blood pressure is fine, his pulse is fine, he looks comfortable. All he has is a penetrated wound to the side, in the gluteal region or something like that. And I send the patient home, right? Okay, without informing the doctor because the patient looks fine, right? They come back now, they realize that most of the rectum is extraperitoneal. So any penetrating wound in the region of the buttock, you got to take seriously, right? Okay, so the penetrating wound is going to go to extraperitoneal rectum. Most of it is extraperitoneal, right? Okay, and that patient can have a little leak there to the small, sometimes an ice pick, right? To the ice pick, right? Get to the small wound caused by the ice pick. And the person really is sent home and then comes back now with a sick like anything, with an abscess and high temperature, white count 30,000 and all that, has an abscess around the rectum there, right? Okay? So anybody who has any penetrated wound around the gluteal region, right? Okay? Right? You have to think of a rectal injury and you call the surgeon. Let him, at least most you can do, put a scope up there and see if there's any injury to the surface of the rectum inside. Before it's at the moment, don't think that because of this, having symptoms. All right, so the rectum now, right? Two curvatures. How many curvatures do we have? Lateral. Somebody knows. How many curvatures lateral? Huh? 3. That's the mind. Tell me where these curvatures are. Right? How many on the right side and how many on the left side? Okay, I can't show you because it's just a lateral. Right? Okay. Right. But this is a image here of the rectum. And first of all, I should tell you that the rectal mucosa is thrown into what we call transverse rectal folds. Let me just go to those first and show you one of them. Right. Actually, I see one right here. Right. Okay. The transverse rectal fold here. Some of them actually with time in a cadaver, you really can't see them very well. I'll show you an image there, right? Okay, the transfer of rectal fold. The fold of mucosa pushes into the rectum about 1.5 centimeters, and it does not look mucosa. It has some circular muscle, right? Okay, so here we can see circular muscle. So there are 2 of them on the left side and 1 on the right. Right, okay, so these are called the transverse rectal folds of who? Whose name? Huh? Houston, very good, okay? And those rectal folds, right, those transverse rectal folds, they help to sort of, you can use them as a guide, or you can see the curvatures. There's usually 1 large curvature, right, okay, to the left, and 2 to the right. The upper right rectal curvature, you can see URC there, a lower right rectal curvature here, and a middle left left arm curvature. And the large middle one, right, is delineated by the upper and lower transverse rectal folds of valves of Houston. And the middle one, right, again, that divides these, separates these 2. Separates the 2 on the right, and this one, these 2 here, further delineate that left side one. All right, okay? It's very important. What's the function of this folds? Let me show you. So, my younger days, when I first started, and I was a resident in Britain, we used to do the endoscopies. I actually learned to do flexible sigmoidoscopy and colonoscopy in England. Right? Before, a lot of physicians have now taken it over. It's the physicians who are now doing the endoscopy. Surgeons don't mind, let's work for us, okay? But this patient had an endoscopy, right? Okay, for whatever. A lot of them are actually screening endoscopies for people who are colonoscopy, right? That's passing an instrument up your anus, right? Okay, and usually a little bit sedated, right? And you're looking up there now, right? And you're seeing three folds, right? This is what they look like on endoscopy, right? So two on the left there, right, and the one on the right. All right, okay? All right, so you're looking up here, and that's what you do is you distend the rectum with air. You always have to see the lumen ahead of you to push the scope up. All right, okay? I haven't done a colonoscopy for a long time. All right, okay? All right, but I don't miss it, to be honest with you. All right? Okay, so the two curvatures. Now, so we spoke a little about the mucosa, it's shown in the folds. What's the function of the valves of Houston? Yeah, somebody else. Where's my girlfriend from Evriana? Where's Evriana? Evriana's not there? From Westmoreland. Evriana? No? Evriana. Evriana answers all my questions. Lisa Marie Whitaker. What's the function of these valves of Houston? Anybody knows? Support the fecal mass and prevent overdistension. If you didn't have them, you'd be sitting on the toilet seat all day long. Right? Okay? They hold the feces up so they don't impinge on the upper anal canal. Okay? If they impinge on the upper anal canal, little bit going to enter in there and you get the feeling that you want to pass something all the time. So that's how to support the feces. All right? Okay? It's very important. Right? Okay? Right? Very important. Okay, now we say that most of the rectum is extraperitoneal. All right, well, let's look at some of the fascia around the rectum. All right, okay? So on the wall of the pelvis, everybody knows that this is the true pelvis. This is the pelvic rim, right? Pelvic rim is made up of the sacral promontory, the ala of the sacrum, the the iliopectineal line, which is called the arterial line here, over the ileum, and then as it gets here, right, it gets sharper, and it's called the pectineal line, the pubic symphysis, right around here, okay? Right? So there is a peripheral fascia which coats the sacrum, right, okay? Right, call it parietal fascia, which coats the sacrum, coats the sacrum and the muscles, the piriformis, levator ani, and there's a peripheral fascia, right? What is it called in the region of the sacrum, right in front of the sacrum? Anybody knows? What's it called? Presacral fascia of who? Come on, Donnie Johnson. Presacral fascia of who? Whose name? Of Waldi. Of Waldi, right? The presacral fascia, right? Waldi. Right, so let's see if we can find it. All right, okay? So we cover the sacrum here, right? Okay? And here we see the presacral fascia of Waldi. Right? This is the presacral fascia of Waldi coming up here. Right? This is the presacral fascia of Waldi. Right? Okay? Presacral fascia of Waldi. Now, what would we find behind the presacral fascia of Waldi? Anybody can tell me? You can find the medial sacral artery, right? Okay? Two lateral sacral arteries, and a nerve, right? A nerve which I'm going to show you a little later called the hypogastric nerve, which runs from the superior hypogastric plexus to the inferior hypogastric plexus, right? So those are behind it, right? Okay? Now, coming to something controversial, right? Okay? Because when I first started doing surgery, we never probably understood the anatomy here all that well, right? Okay? And many times I was taught to do patients, cancer of the rectum is very common. So sometimes they have to take out the rectum and then give them a permanent colostomy. Or if you have enough normal rectum underneath, you can bring the descending colon down and anastomosis downwards. Right, okay? Right, that's called an anterior resection. I don't want to go into that today. But I had to dissect out. After dissect the sigmoid like I did in the previous thing, I have to dissect the rectum. Right, okay? So I see this, we're taught just to get our hand down with this plate here. Right? Easy, really very avascular, and just enucleate the rectum. All that has changed now. All that has changed. Because it's come to light now that there is a, see, we always thought that the rectum doesn't have a mesentery. We know it doesn't have a mesentery. We know it doesn't have a mesentery. Anal sex causes anal cancer? No. No. Only if you transmit. It's usually dietary, most of it are hereditary. But usually, only if you transmit HPV, probably that will cause rectal cancer. All right? But what I'm saying to you is that this is the presacral fascia wall that I was saying here. There's another fatty layer, right? Okay, right? We found out today, right? It's very important, right? Okay, so most could I would advise today that rectal cancer be left for the colorectal surgeon or general surgeon who's well trained to do what we call a total mesocolic resection of the rectum. And the reason is this, is that we now appreciate that this layer here, you see, the rectum doesn't have any peritoneum for most of the way. So what lines it is a picture. Pictures in the last step, right again. So here is the, right, if we look here, cecum, right again, okay, ladder, rectum, right? Here's the presacral fascia wall there. Upside down. Here's the presacral, so that's the cecum up here, and the presacral fascia wall there. So here we have the hypogastric nerves behind it. Then we have the medial sacral, lateral sacral. Right, okay? Right, okay? But the superior rectal nerves, superior rectal artery, right? The superior rectal vein, okay? And the lymph nodes. You can see them there? All these lymph nodes here. Look there. Like the green thing there, the lymph node. There's another lymph node. Right, okay? The lymphatic, right, okay? They are within a layer of fat, right? That's within. You see, this rectum doesn't have any mesentery. It just has an adventitia. This is the adventitia here, which they call the rectal fascia, right? So that's what they call it in this image, right? Okay? But within that, you have a layer of fat, which is more, right? Okay? Which is more, oh, sorry. That's why I turn it that way. It's more posterior, much more posterior, right? So where the superior mesenteric artery runs down, right? Okay, branches, superior mesenteric vein, and the lymphatics is in a layer fat, which they're not, the anatomists today, who are real anatomists, who believe that a mesocolon means that it's a mesentery. And quite rightly so. So they think that using the mesocolon, right, it's the mesocolon of the rectum, right, okay, to describe it is not the right thing. And probably there's a little bit, but we call the operation, right, by getting into a plane, which I'm going to show you, a total mesocolic resection. Because we want to go into this layer here, right, between the adventitia of the rectum, right, okay, but you can't just go on the surface of the rectum. There's a significant fatty layer, which we can see more behind the rectum, posterior to the rectum. So here, what we're seeing here is mesorectum. But then again, you know, pure anatomists don't like to call it. It's more a surgical term, right? Okay. So this fat here is on the rectum. This is the fascia of the rectum. This is the presacral fascia back here, right? It's very important to grab that. So what we want to do is to get in this plane when we're removing the rectum, right? I have a little diagram here to show you. So if we look here, right, right, see the mesentery, the peritoneum ends up here, right, okay, right, okay. So start here. So this would be the sigmoid here, right, okay, right, okay. So the peritoneum ends here. If we look down here now, we see behind the rectum, posterior wall of the rectum here, we can see this fat here. Back here now is the presacral fascia wall line. Right, okay? And this fat here, right, has to be removed. But there's a plane here between the presacral fascia and what I'm calling the mesorectum, which is not purely an anatomical term, because it's not a mesentery. Right, okay? That's what it's called today in you go to the hospital, right? Okay? So we have to change the way we think sometimes, okay? So there's a plane now between the presacral fascia wall there and the mesorectum, which is mainly behind the rectum, right, okay, right, okay, right, okay. And here what we're talking about now is the fascia propria, which is the adventitia, right, okay. But this thing is within the fascia, the fat is within the fascia propria. This fascia, this fat is within the adventitia, right, okay. So we have to try and work in that plane. Now, long ago when I used to do that operation, that's not the total. I would just, when I used to take out the rectum, I used to just go down here. But I can breach that plane by doing blunt dissection. So what they do now, they have lighted retractors. And a lot of these operations are being done endoscopically, laparoscopically. And they have angled retractors that are, because you're working down the sigmoid, in the rectum here, in the pelvis here. It's not easy, especially a male with a small pelvis like this. Right? It's not easy working down there. Put a hand there and mobilize the rectum posteriorly. That is, you know. But now they do sharp dissection between the mesorectum or the fascia propria or adventitia of the rectum and the go faster, right? And the wall fascia. Now there's another fascia anterior. What's the name of that fascia? Anybody can tell me? What fascia? What fascia are you going to find anterior? Can you pull the camera down, please? Oh, what do you mean pull the camera down? The camera is jumping, the images are jumping, so I think we got this picture we can right now. Right, okay? All right, okay, Shania, right? Okay, what's the name of that, this fascia anteriorly? Somebody can tell me, what happens behind? This is the bladder here, this is the prostate, right, okay? Right, this is the prostate here, right, okay? Right, I have a better one to show you. This is the seminal vesicle we see in there, right? This is the ampulla, the vas, but I have a better one to show you, right? Okay. So if we look now, we see a fascia now between prostate, right? Okay, and these seminal vesicles and ampulla of the vas, which you don't have to know about right now. This is this fascia right here. Right? The anterior side of the rectum. What's the name of that fascia? Starts from the, look at where it starts. Starts from the rectovesical pouch here, right? Okay, from the rectovesical pouch is attached here, and it runs right down, right, to the levator. What's the name of this fascia? Anybody can tell me? The rectoprostatic fascia. What a name? I like a name. What name? Oh, of Denavilla. Very good, Sydney. Sydney on the ball. Sydney really on the ball. Right, okay? Excellent, Sydney. Right, okay? And that fascia is very important because the urologist will tell you it separates poo from urine. You understand me? So you don't want to breach this fascia at all either. So we try to work behind this fascia. Right, okay? The fascia of Denavilla. Right, okay? So those are the fascia you should know about. All right? So all these things that support the rectum, right? Fascia Denavilla, the Veta 80, right? Fascia, sorry, all the fascia, right? All the fascias are over. So you have to know the fascias. All right, okay? Now let's talk a little about the arterial supply. And Let's have an artery supply the venous and the venous drainage. Lymphatics. All right. So I showed you this here rectal artery. This will be a rectal artery. All right. Okay. By the way, this artery here, right, this one makes up. There are four arteries that supply the rectum. The most of what supplies the rectum is the superior rectal artery. So here's the inferior mesenteric artery right here, guys. Right, everybody can see? Yeah, inferior mesenteric artery. Passing in front of the left common iliac artery, as I showed you. Giving off left colic branch up here, sigmoid branches here, and then passing down now to S3. We're going to pass behind the rectum, but behind the rectum in the mesorectum. In the mesorectum. But that mesorectum is not really a mesentery. So it's a bit of a misnomer, and that's why the anatomists and the surgeons quarrel about it, but using that term. But I've explained what I mean by it, right? Okay, it's actually fat within the adventitia of the arm. So that's where these are going to run. They're going to run on the rectal wall in that mesorectum, right? Okay, behind the rectum, right? So it comes down here. It's going to divide the right branch. But what we've done here is that we've removed the back of the sacrum, so we're looking at the rectum. We remove the back of the sacrum there, so we look at the rectum. So what we've done here, back of the sacrum. So we look at the rectum. So here's the superior rectal artery. It divides into right branch and left branch. Right branch subdivides into anterior and posterior. And you can find that very important when it comes down on top of the vascular cushion. Right, okay? It's going to run right down, right here, and it's going to divide into branches which are going to penetrate, supply the musculature, penetrate the musculature, run down under the submucosa, and supply the whole rectum all the way down. And then down here now, as we get into the anal canal, the terminal branches are going to enter. The terminal branches of this are going to enter into the upper part of the anal canal, into something we're going to show you called the columns of Morgag. Columns of anal columns of Morgag, which show you. All right, okay? All right, so that's the superior artery. All right, okay? Another supply comes from the internal iliac. So here is the common iliac. Remember, we're looking from posterior. So that's the external iliac going down on the pelvic rim there to go down into the lower limb, right, as a femoral artery. This is the internal iliac artery. Right? That showed you that earlier. Well, I didn't get to show you the internal iliac artery. It's difficult to show you. I'll show you in another specimen, the female specimen. Right? Internal iliac artery, one of its branches on anterior division, right? Okay, is the middle rectal artery, which runs in and supplies a small part of the rectum right here. And the inferior rectal artery now, right, which comes off of the anterior division of the internal iliac artery again, that I'm going to show you, is going to run right into a canal, right, okay, call it, right. So inferior rectal artery is going to leave the pelvis and run in a canal just inside of the sacrotuberous there, called the pudendal canal of Alcock. And there it's going to give this branch called inferior rectal artery, which is going to supply the anal canal, main artery for the anal canal. But there is very significant communication between the inferior rectal artery and the superior rectal artery at the lower ends of the at the dentate line. It's significant. So it can also help. It's one of the arterial supplies of the rectum. So we're going three, right? Main one is superior, second one is middle rectal, the other one is inferior rectal artery, which I'm going to go into more detail when I get to the anal canal. Right, okay? And here we also have a little one come off just the bifurcation, just the bifurcation of the common iliac there. That's the one that runs down behind the presacral fascia of Walleye. And that's a small artery that supplies a little bit of the surface of the rectum, but not much. Okay? Not very important. Now, we're going to spend a lot of time when we get to the anal canal talking about the columns of Morgag, which are right here, the upper part of the anal canal. right, okay? So those are terminal, these are terminal radicals here, right, okay, of the superior rectal vein, right, okay? And then here, the inferior rectal vein running in pudendal canal again, running across the inferior rectal fossa, right, to get supply to drain, to drain blood, venous blood from the anal canal, lower part of the anal. So this will be the dentate line right here, which I'm going to show you in a little while, right, okay? And then we're going to talk about this, the other name for it, right? It's called the internal hemorrhoidal veins, right? Okay, and these are called external hemorrhoidal plexus, internal hemorrhoidal plexus. These are the branches. All you have to remember is that they're branches of the superior, the terminal radicals of the superior rectal vein, right? And these are branches of the inferior rectal vein. It is going to drain. That's going to drain back along the pudendal canal and into the internal iliac vein here. All right. So let's try and move on. Right. So here, that's going to go up now, and it's going to the branches are going to come now, and they're going to form now superior rectal vein, which then drains as it crosses the pelvic rim. It becomes the inferior mesenteric vein, which I showed you earlier. Inferior mesenteric vein that runs up between the superior rectal artery, right, okay, and the ureter, right, okay, and goes up and joins the pelvic vein, right, okay. That's the arterial and venous drainage. I'm not sure. I'm going to go over this part when I do the anal canal. All right. I can't think of anything else. Oh yes, we need. Well, I'm going to do the anal canal, and then I go into the innervation. All right, I'm going to do it, and also go over blood supply. So let's get into the anal canal. All right, okay. I can't think of anything else. Oh yes, relations. Okay, so in the male, pretty easy, right? Okay, right. The upper 2/3, right here, right? Okay, and the upper part 2/3 right here is it's the the, the rectovesical pouch. So what's going to happen? The sigma colon will lie down in there, right? Okay, so the upper 2/3 there, sigmoid colon, and then you're going to have even jejunum, ileum, right? Many ileum, right? It can sit in there, right? Okay, so that's the rectovesical pouch. As we get down to the lower third now, right down here, right? Okay, it's the fascia of denonvillia, and then we're going to have the male. We're going to have these things: prostate, right? Okay, ample of vas and seminal vesicles. What I'm going to do right now, put the phone aside. Another one, another better. Better. It doesn't have, some things are not better, some things are better. Here, we have a little bit here. See what happened? The rectum here has been cut a little to the left. What you see in here is the rectal fossa on the left side. Right, okay? Rectal fossa over here. Right, okay? But this is more on the left side here. It's not really seen here. All right, but this is the end here of the rectovesical pouch. Here we have the fascia of denonvillia coming down, right? So now we're going to look at the things that are in front of it. If we look, prostate, this is the prostate gland here, prostate urethra, running right there. If we look here now, you can see coming through the internal, right? You can coming through the internal ring of the inguinal canal. We can see the vas deferens. So it's the vas deferens, okay? Vas deferens coming. We're going to run a beeline across the pelvis like that. We're going to run down on the iliac vessels right here, external iliac, the external iliac vessels here, right? Okay, run over here. And then as it comes down here now, right, it's going to become dilated, right? Sorry, it's going to pass ureter. Very important. Well, I shouldn't be telling you all this. So this is for you, to you. Very important relationship you're going to know in GU. The anterior relation of the lower end of the ureter. And that's it. In the male, it's the vas deferens. All right, okay? All right, here now, the vas deferens. And if you look back here now, right, big boy over there, right? I don't want to dissect it anymore because we need to tear it as a seminal vesicle here. So this and the seminal vesicle are going to join form a duct called the ejaculatory duct. So when you're ejaculating, the semen come down here, it's going to get, what's coming down here now, just spermatozoa. The volume of the semen is going to come from this boy here, right, again, which is seminal vesicle, and from the prostate. Right, so if we squeeze that, we see fluid coming out there, right? That's where that's the ejaculatory duct. Ejaculatory duct is going to run through. Here you can see it run through the prostate to join the prostatic ureter. But anybody looking at this video will think that I'm talking about genital urinary, right? But this is just showing you the anterior relations of the lower end, okay? Then in the fascia, the prostate, right? This is also called the rectal prostatic fascia, right? Okay, of the ventral. All right, so that's all I think we need to know here. Let's look at the female. All right. All right, so very good. All right, so here we go. All right, this what we have here is that's sigmoid colon coming down here, rectum upper part of rectum here. All right, okay, and then we're coming now to right, okay, rectum probably starts. Yeah, no, probably below that. Sigmoid back and then here, and rectum here. So what we have here now, the in front, we have the bladder. Right, okay, this is the urethra coming here, bladder, and this is the uterus. This lady was, she's a person who was had never had children or anything like that. She's in an elderly person, the uterus is atrophic, right? Okay, it's the atrophic uterus, right? And here is the vagina, right? That's the vagina. Right, okay, the vagina. And this is a part of the vagina that you'll know hear about when you come to do a GU called posterior fornix, right here. So the cervix is here, the body. So we can see a small fibroid here, the uterus, one here, another one here. You would never give any trouble in life, eh? One of the big ones with trouble. All right, so that's the bladder, the vagina, and here now, right? Who can tell me the name of that pouch? Who can tell me the name of that pouch? Who can tell me the name of that pouch? That peritoneal pouch, you see the feet. What's the name of it? Jada chin. Pouch of Douglas. Very good. Everybody got the answer right. Okay. Pouch of Douglas. So in the female, it's not called a rectal. Can be called a rectal uterine pouch, but everybody knows it as the pouch of Douglas. The anterior wall of the pouch of Douglas is really going to be the posterior fornix of the vagina and the body of the uterus. Right. Okay. Now, what's going to be in here now? Upper part of the rectum is going to be the same as in male, right? Sigmoid, colon, small bowel. When you come down here now, right, okay, it's the vagina. The lower part is the vagina. And in between, right, there's a fascia which separates, septum, really, they call it, separates the vagina and the rectum. Let's call it rectovaginal septum. Right, okay? So those are the anterior relation down here. Right, okay? It's the arm. It's the arm. Anterior two-thirds is the Portia Douglas and the contents. And then inferiorly now, instead of the fascia dead on villia now, we have the rectovaginal septum and the vagina. Right, okay? And the posterior fornix. All right? I want to show you here the second out, right? Female, right? Okay, so that we can actually in the female, so we can actually see. I'll try to show the students in view how the uterine artery comes off of the internal iliac. So this is the external iliac. This is the common iliac here, right? Common iliac. The external iliac is a little bit tortuous for the elderly lady, and this is the internal iliac. Internal iliac is going to go down, divided from posterior trunk and anterior trunk. Anterior trunk is going to give holy a lot of branches. But you don't have to know that that's for UG, right? That's for UG. The pelvis, you don't get to know the pelvis in detail until UG. You just have to know about rectum relation with the rectum relations. Right, okay? So, any questions? Any questions at all? I'm finished now. Anybody have any questions before I go on to the anal canal? Anybody? Couldn't have understood everything I said, did you? Tomorrow morning, we're going to be doing I go over the pelvic diaphragm when I'm doing the rectal fossa with you at 9 o'clock. Skeleton, have a direct message?
No, that was from before.
So I'm not going down there. Got a hold on one block was unchanging. So, go ahead now, anybody else ask anything at all you want to ask? After do the anal canal, I'm going to do the innovation. Right, okay? All right. Should change close. I don't understand. All right, so let's go back to the first one that I had. First, all these are my sections. So this is the one that I picked out for you. Because it's the one.
Someone was asking about blood supply.
Blood supply of what? Go ahead. Could you repeat the blood supply? Okay. Right. The rectum, that's the blood supply, and the canal. That's why I'm going to go over it again. Right, okay. So probably I can just leave it till I go. Right, so you get along. Right, okay. So when I get to the canal, after showing because those features and all that, then I'm going to I'll just run over the blood supply again. All right, okay. But remember for the rectum, it's 4 arteries. Main artery is the superior rectal artery, then the middle rectal artery, inferior rectal artery, then we talked about more now. All right, okay. So here, guys, is the sacral curvature, and this is the perineal curvature. Now, you never see, I'm going to show you an image because you never see anything. Right, okay? Right? But what I can show you here is that in the upper part of the anal mucosa, we have these folds. Why do that? Right? So I like this image because just imagine that what we're doing here is showing you, this is the right, this is the left side. What we're looking at here now. Cut down would be the right side. Okay? And that would be the sacrum here. Right? Okay, then you have the curve, right? So here the curve of the sacral curve, and then this curve now is perineal flexion. Right? Okay? That is going to happen. tomorrow I'm going to show you this, right? Okay, right, this image here, and what I've got to it already. Right, so this part here, right, is the UG triangle. You don't need to know anything there right now. This part is the inner triangle. What we're seeing here is the lower end of the pelvic diaphragm. Right? So what this will be here, this will be the pubococcygeus, right? Okay, coming here, and this will be the iliococcygeus, forming the levator. Remember that the coccygeus is a very weak muscle, right? And I'll be going into that tomorrow. So it's sort of hidden under here. This is the gluteus maximus covering the sacrotuberous ligament right here. The sacrotuberous ligament is here, right? Coccyx is here, pubic symphysis is here, ischial pubic is here, right? So we have the perineum here, the quadrangle of the perineum, divided into two triangles. Okay, so this is the anal triangle. So we see in the anal triangle, it's the anal canal here, right? The lower end of it from outside, right? Okay, then we have the ischiorectal fossa, which I'm going to be talking about plenty tomorrow morning in my lecture at 9. Right, okay? And then on the side wall, I have a section to show you the pudendal canal. All right, so I just want to talk about a few of the features of the anal canal first, and then I come to talk about the pudendal canal and the inferior rectal artery, pudendal nerve, inferior hypogastric plexus, and all those things. All right, okay? So as sacral curvature, okay, sacral curvature, which is here, makes this turn, we see it here, right? Okay, this is the anal, with 4 centimeters long. Upper part, let's just start with the mucosa, and then we come to this pelvis. Well, I'll tell you what, let's get the muscular part out first, the outdoor first. Because here is a very good image of the two parts of the muscular part of the anal wall. This is the sphincter externus, and this is the sphincter internus. Right? Sphincter externus and the sphincter internus. I can't really show them to you on this, right? Okay? Right? Sphincter externus. This is a blue link image from University of Michigan, and just put a lot of effort into this. I think this is plastinated also, right? And this image may have been magnified a little. All right, okay? You can see the upper part of the anal canal. Well, sorry, let's get back to this. This muscle here, right? The sphincter externus is striated. All these fibers are circular around the anal canal. This muscle is striated muscle, right? Capable of prolonged contraction, is what they call type 1, large fiber striated muscle, capable of prolonged contraction. After you finish your bowel function, that muscle goes into contraction, right? Okay, and you don't have to. Right? It means constant within contraction. It is supplied by the pudendal nerve, by a branch of the pudendal nerve called the inferior rectum nerve. The inferior rectum nerve, which I'm going to show you. All right, inferior rectum nerve. Right? Okay. All right. Now the 3 parts to it: the deep part, a middle part, deep part, a superficial part, and a subcutaneous part. Right? And they all have different characteristics. This image comes from last. Okay, this is the sacral curvature. This is the perineal curvature. That gives you the anal canal. So we look at sphincter externus. The deep part, right here, right, okay, is going to, fibers are going to intermingle with the tuberoctalis, which is the medial aspect, the medial fibers of the sphincter, of the medial fibers of the pubococcygeus, right? Remember we say we're looking at them below here now. So the pubococcygeus, this is the iliococcygeus, right? That's the pelvic diaphragm you see there, right? Okay. So this is the deep part of the sphincter externus. Fibers are going to intermingle with the most the medial fibers of the, and tomorrow morning I'm going to go over the pelvic diaphragm when I do the ischial fossa. Right, okay? So the medial fibers of the pubertalis, they sling around the interrectal junction. That's what they hear. And that's what gives you the perennial flexure. Perennial flexure is when the rectum slings over the pubertalis. The diaphragm is going to extend out from here. These are the most medial fibers of the pelvic diaphragm, right? Called the pubertalis, part of the pubococcygeus. Now, those fibers that come here, as the pubococcygeus arises from the back of the pubic bone here, right? Okay, and another section I have, I'm going to show you also where the ischiococcygeus is going to arise, right? So from the back of the pubic bone here, here, pubococcygeus arises, and then the iliac, is better?
No.
Sorry.
Towards it, right? Towards it, right?
No, sorry,
Right.
That's it.
Mm-hmm.
That's what, okay, all right? The iliococcygeus is going to, remember that the obturator internus arises around the obturator foramen, right here. So the iliococcygeus is going to arise from the fascia over the iliococcygeus is going to arise from the fascia over the obturator internus, which is called that's called the arcus tendinus. Arcus tendinus, right? Arcus tendinus, right? Okay, and then those two muscles are going to, fibers are going to go back immediately, right? Okay, so let me just show you. Fibers are going to go coming from up here, but come backward immediately, and then they're going to behind the rectum. They're going to.
Exactly about the two stones at the top.
The what?
What are these? Don't think there's two.
No, sorry. Oh no, what we've done here is just push the scrotum up there. So the testes are there. All right, okay? Penis is put up there. All right, okay? So this is a male. All right? So these fibers now, they're going to be inserted into a raphe. It's not this raphe here. It's a raphe that's under this, right? Okay? Right? Which is called the anococcygeal raphe. Right? And this here is the anococcygeal raphe. That's in the pelvic diaphragm meet, right here. You can see anococcygeal raphe here. Right? Okay? And that's where the medial fibers of the pubertalis, and then this is going to sling over like that. Right? So the deep part of the sphincter externus is going to, fibers are going to intermingle with the pubertalis. That's the medial part of this muscle. Right? Then the middle part now, which is this second part here, that's that middle third. This is the deep, this is the superficial part, right? Okay, superficial. This is three parts: deep, superficial, subcutaneous. Superficial part now, that's going to go, and tomorrow morning this is going to become quite clear when I go over the pelvic diaphragm. All right, okay? I don't have a model or anything here to show. But that superficial part now, it has a forward extension to a fibrous body right here called the perineal body. It provides attachment to all these small muscles around here, from the anus and all these muscles around the genitalia. That's the huge. And then it has another part now, right, that's going to go back now to the tip of the coccyx. That's the one you see it here. Right? Okay, so it has an extension to the perineal body, an extension backwards to the tip of the coccyx. Now that is below, right? Okay, the anococcygeal raphe. This one is called the anococcygeal ligament. Anococcygeal ligament. And I'm going to show you tomorrow, right? Okay, in the lecture. There's a space here, right, between the anococcygeal ligament and the anococcygeal raphe. We call the retrosphincteric space. Very important when it comes to the ischial fossa, which I wouldn't be able to go into too much today. Right? Superficial part now, subcutaneous part, sorry, just under the skin. right on the skin of the verge of the anus. It's right here, right on the skin of the verge of the anus. Right, okay, so 3 parts. Right. Now, coming back now, right, we find that the circular muscle of the rectum, remember the rectum has longitudinal and circular muscle, that is going to come down here now, and that's going to be the sphincter internus. The thing about the sphincter internus is that it doesn't go all the way down, right, okay, to the end, to the end of the sphincter externus. Right, so there's a groove here, called the intersphincteric groove, which you can feel, right, when after you become quite good at it, like after you train in surgery and all that, you can feel that intersphincteric groove. Much easier than when you first start doing a rectal examination. Okay, so the intersphincteric groove coincides with a line, which we call the white line of Hilton. Right, okay? This sphincter internus now is smooth muscle that's under control of the autonomic nervous system. Autonomic nervous system. All right, so let's leave that for now. One other thing we should be thinking about also, and I went into that with a lecture, so I'm not going to go into that today, is the conjoint longitudinal cord, which really is remember that there's a longitudinal muscle in the rectum that is going to become fibroelastic. It's going to give a ligament that's going to go to the dentate line, or the mucosal ligament of Parks, right? Okay, and some other fibers that get inserted skin around the anus called the corrugator through the skin. But I want to get to the mucosa, right? Okay, because upper part of the mucosa is thrown into folds. There's longitudinal folds, right? Okay, which we call the inner columns of our back. And you can see them here. Right? Everybody can see them here. Right, okay? If you look in this, right there, you can see them here. Right? Right down here.
Too much? Too much?
No, you can see them. Okay, here we go. There they are. Right? They're not easy to show. Right? Okay, that's why I have this image to show you. Yeah. Yeah. But I went over this in the lecture, right? Okay? Because of the inner columns of Morgagni. Each one of those okay, guys, so when we describe the anus, right here, right, we're describing the anus as this part of the anus, which is anteriorly, right, is 12 o'clock, right? Part here is 12 o'clock, and when the part that is near to the coccyx.
Let me do. Right.
Okay? Part that's near to the coccyx is 6 o'clock. Right, okay? So these columns, and there were 8 of them. The very numbers are a lot, columns and all that. So this is an upper column. Each column has a terminal branch of the superior rectal artery and a terminal branch of the superior rectal vein. All right, okay? So that's the same thing I showed you earlier. Superior rectal artery, right? In the terminal branches are in those columns, right? Okay, all right. Now, at about 3 points, right? Okay, in those columns, there are a lot of arteriovenous. So this is 12 o'clock. This is 6 o'clock. So posteriorly, this is anteriorly. So on the left hand side, right, okay, because it right would be here, right, okay, right, okay, the patient is in this position. So the left hand side, right, okay, that would be 3 o'clock. About here would be 7 o'clock, and here would be 11 o'clock. These terminal branches of the superior artery and superior vein, they have significant amount of arteriovenous communication between them, right? Okay, and they cause submucosal proliferation at that point, right? Okay, because of this increased anastomoses, and they're called vascular cushions. They call vascular. I can't show them to you, right? They're not easy to show unless you're really hemorrhoid, right? Okay, right, and those are the sites, right? Okay, which sometimes can become hemorrhoid, right? Okay, so when we do get hemorrhoids like these, right, and this is a large hemorrhoid, it's 12 o'clock, 6 o'clock. These are very advanced hemorrhoids. Most people have hemorrhoids just have mild enlargement in the columns. So when stool passes over it, they get a bleeding. But with time, they get big and they start pushing through. This is called a prolapsed hemorrhoids. These depend on need surgery. They can be reduced, but eventually they're going to need surgery because they're not too big to manage by conservative means, which I don't want to go into today. Right, okay? Right? It's internal hemorrhoids. So you should know about it. About this. Right now, at the lower end, this is the dentate line you see in here. So these are the columns of Morgagni.
You just focusing on the picture or?
The picture is right, it's right. You can see the columns of Morgagni here. Right, okay? These are the terminal radicals of the superior rectal vein. You're going to drain up that way. But the inferior rectal artery, right, okay, is coming in here from the pudendal canal, right, okay, which I'm going to show you where that runs. And then that's going to cross the ischial fossa, which I'm going to go into again with you tomorrow morning, right, okay, right? But I'm going to have a dissection which I want to show you with the pudendal canal. So remember, the pudendal canal is transmitting an artery from the anterior branch, anterior division of the internal iliac artery, right, which is going to run in the pudendal canal. So let me see if I can explain it to you. So I showed you in the female where the external iliac artery is here, the internal iliac artery is going down. Coming out from the anterior division is going to be by the way, everybody should know that this is the greater sciatic foramen, this is the lesser sciatic foramen. This is the sciatic tubercle, right, okay? All right, okay? All right. So remember that we have a sacrospinous ligament that goes to the spine here from the sacrum, and a sacrotuberous ligament that goes to the ischial tuberosity here, right? Okay, so we have two foramina that leave the pelvis, right? Okay, so this is the greater sciatic foramen. This will be the lesser sciatic foramen. This thing is coming out here, right? Okay, right from here. Sorry, right, coming out here, right? Okay, right, through the greater sciatic foramen. Right, okay. Then it's going to run in the gluteal region for a short time. Gluteal region for a short time. What's that? I'm going to do it. Yeah, no, sure. Just go right this way. All right, okay, all right. So here, guys, yes, you can do that. That's fine. I don't have to move. So this is sacral plexus, eh? Right, okay? Again, you're not going to supposed to be doing this until you do the YouTube. So I just want to show you that this is the lumbosacral trunk here. This is the obturator nerve. Right, okay, going into the obturator foramen. This is the lumbosacral trunk, L4, L5. This is S1, S2, S3. The muscle that's behind it is the piriformis. If we look here, this what you see in those fibers there under here, that's up to return to us. It's up to return to us. And what these fibers coming down here now, right, okay, are coming, it's been taken away, are coming into the pelvic diaphragm. So this, here will be the ischiococcygis, and the pubococcygis will be from here, from back here. These fibers are running like that, right, okay, and they're going to form in the midline, right, to form. All that stuff has been removed, right, okay? Right, so I just want to show you that the internal iliac artery running down here, one of the branches is going to come out to the greater sciatic foramen, coming out to the greater sciatic foramen, and it comes out to the greater sciatic foramen. Just take it back to the locomotor, show the greater sciatic foramen. Okay, remember, right? Everybody remember this? Everybody remembers this muscle here? The landmark of the gluteal region. What's the name of it? What's the name of this muscle? Landmark of the gluteal region. What's the name of it? Anybody? Piriformis, right? Okay. So and this is the sciatic nerve you see coming here. Great sciatic nerve running under it. Well, medially, which I really haven't really dissected out here, right? About here, the pudendal nerve is going to come out, right? Okay, into the gluteal region. It's not going to stay there for long. Just going to make a beeline, right? Okay, and come back inside, right? Okay, then make a beeline and come back inside. So this is what we're doing here now. Come back inside, right? And then it's going to run. Comes out here. As it comes back inside, it's going to hook around the sacrospinous ligament, and it's going to run now. Right? This is the sciatic. Right, okay? Right, okay? And it's going to run here. Right, okay? Sorry, ischial spine. I'm sorry about that. Ischial spine. The ischial spine, right, okay? Right? It's going to run in a fossa, sorry, in a canal that runs on the inside of the ischial tuberosity. And it's going to run towards the UG triangle in front. While it's here, it's going to be called the pudendal canal. So what we're seeing here, this is the ischial tuberosity here, this is the pudendal canal. Right, okay? So I can't show you everything, but I'm going to show you what I've been able to dissect out. This is the pudendal nerve, that's it there, right? So the internal pudendal artery, right, okay? And internal pudendal vein. Internal pudendal artery, right, okay? Internal pudendal vein, this is the pudendal nerve. Right about here, this would be where this is the erector fossa. Right, okay? This pudendal nerve is running now to go up to supply the usually triangle. While it's here in the pudendal canal, the pudendal canal here, guys, all of this, everybody can see it, actually. Nobody's going to ask you to identify this. I'm just showing it to you. So these are the three things: internal pudendal artery, internal pudendal vein, right, okay, and the pudendal nerve. As it crosses now, right, okay, the rectal, so we're running somewhere inside here, right, and not seen on this, right, they're hidden under here. It's going to give off the inferior rectal artery, inferior rectal vein, and a pudendal, and an inferior rectal nerve, which is a branch of the pudendal nerve. The pudendal nerve comes from S2, 3, so this is L4, L5, S1, S2, S3, S4, right? I have another image here to show you, same thing, right? Okay, this is the lumbosacral trunk, S1, S2, S3, right? Okay, pudendal nerve is going to come out here and come back into the, it's going to go out to the greater sciatic nerve, into the gluteal region, then come back into the perineum. right? Okay, and it's going to run in the inner tract, on the lateral wall of the ureter, of the inner tract, right? Okay, all right. That's going to supply the sphincter externus, right? And it's going to provide sensation to the lower part of the abdomen. Supply sphincter externus and provide sensation to everything below it. Now, something I haven't told you is that each of these columns now end, right? Okay. Went over this in the lecture, but I'm trying to go over it with you. Each of these columns are more garden here, end a little papilla, and connecting the ends of them, we have the anal crypts, right? Okay, the anal crypts. Sorry, the anal valves. The anal valves connect the ends. Then the crypts are going to be down under the anal valves, okay? And the anal glands that are going to open that region. All right, so we went over all that in the lecture, right? Okay. Now everything up here, right? Okay, is under the control of the autonomic nervous system, right? Okay, because this is the point where you've done the development of this area with Dr. Barnell. And remember that the lower part of the anal canal comes from the proctoderm, right, which is ectoderm, and up here is endoderm, right? Okay, so everything up here is autonomic, right? Okay, down here is somatic. So the pudendal nerve is going to supply this. The inferior rectal artery is going to supply down there, the inferior rectal vein. But there's significant anastomosis between the inferior rectal artery and the superior rectal artery at the lower end of the sorry, this line here is called the dentate line, okay? Because these columns and the valves, they look like teeth. All right, you can just get the impression that they look like denture right here. We call it dentate line. Okay, so the dentate line separates the upper part from a part below. All right, this part is the enoderm down here. You see in here. That doesn't have any hairs, doesn't have any glands, and it's depigmented. Right? Okay. Now, when we get below now, there's a line called the white line of Hilton, which I can never find, but it coincides with the junction, the end of the sphincter internus and the termination of the sphincter externus, right here. It's called the intersphincteric groove. So the white line of Hilton will be here. The anal canal really has three parts to it. Upper part, right, okay, right above the dentate line, a part between the dentate line and the white line of Hilton, which is just enoderm. That is pudendal nerve territory. So if I'm injecting a hemorrhoid, let us say, and I want to inject, happened when I first started. This hemorrhoid sometimes like this. Trying to get to the neck of it. The neck is all the way up there inside. This is prolapse, right? And sometimes we just inject something around. If you were to miss and go below the dentate line, that patient is going to box it, right? Literally, right? Okay, whereby above the dentate line is autonomic innervation. It's really not very sensitive, right? Okay, so you have to know where you're going.
Was it painful?
Painful. Painful. It's a little bit uncomfortable, but not really painful. And visceral pain is really not as anything as sharp as somatic pain, the pain from below, right? Okay, so people can put up. You tell them they're going to have a discomfort from the injection, they'll accept that. You understand? Okay, so now we're getting to the end, but I'm probably going too fast. There's so many things to talk about. You know what I mean? Anybody want to ask any questions? Anybody? All right, so let's talk a little about the autonomic innervation. All right, I'm going to use this here first. So as you realize, this is a cubic synthesis, right? Okay. So the operator canal here, right? Again, we don't get this. What we see in here is these are the beginnings of these things coming down here, right? Some of the fibers of the levator which has been removed. It's the only way you're going to see all this, right? Okay, all the internal iliac artery, all the arteries and veins. Just show the nerves, okay? I use this for UG mainly, but associated with these nerves here, right, on the side wall of the pelvis, right, is a plexus called inferior hypogastric plexus. Right, okay? So here, you can see the same thing I'm showing you there. This is the obturator nerve. It's almost like a picture of that, right? Okay.
That's what?
Yeah. So this is the obturator nerve. Right? This is the lumbar trunk. S1, S2, S3, S4. Right? Now, way up here, it fronts below the bifurcation of the aorta, where it bifurcates the common iliac and internal iliac, there is a superior hypogastric plexus. This is sympathetic, right? Okay, right? Superior hypogastric plexus. Now, the sympathetic neurons, right? Okay, which are going to be they made a vasoconstrictor, right? Okay, and they are also will inhibit the sphincter. That's basically. Remember that the main autonomic innervation of the bowel, as far as we're concerned, is the parasympathetic. Rest and digest. Right? Okay? The parasympathetic is rest and digest. It helps the motility of the bowel, it keeps it relaxes sphincters, the parasympathetic. They're all two neuron systems. Eh? So you have a preganglionic sympathetic neuron and a postganglionic sympathetic neuron. A preganglionic parasympathetic neuron and a postganglionic parasympathetic neuron. Now, this superior hypogastric plexus contains three ganglionic neurons whose ganglia, whose neuronal body, right, okay, is in the spinal cord in L1, L2 segment, in the lateral horn. Now you haven't done neurons yet, right, okay? They're going to come out through the lumbus phalanx and run here. And then they're going to come down through these two nerves behind the rectum that run behind wall fascia, called hypogastric nerves. These hypogastric nerves are then going to come to this plexus here, which is the inferior hypogastric plexus. That inferior hypogastric plexus is right on the side wall of the pelvis, right on the side wall of the pelvis, right? So right on the side wall of the pelvis. You're not going to be asked to identify it, right? Okay? So it's right on the side. It's on the side of the rectum and the side of the bladder, right? Okay, and this inferior hypogastric plexus is probably one of the most important autonomic plexuses in the body. Look, it's going to help to control defecation, right? It's going to help to control, right, as you get to GU, right? Well, micturition, passing urine. It's going to help to control erection, ejaculation, parturition, right? Okay, and the sympathetic is L1, L2. And they get there by going through the superior hypogastric plexus. The hypogastric, by the way, what you see in here is the sympathetic chain. The three neural factors that cross it, three nerves that cross the ala of the sacrum, the obturator, the lumbosacral trunk, and the sympathetic chain. That's just by the way. So the sympathetic chain comes down here. Some of these fibers also contain preganglionic neurons that will go into this. But most of them come through the superior hypogastric plexus, hypogastric nerve, inferior hypogastric plexus. At the same time now, if you look at L4, L5, S1, S2, S3, S4, you see three little nerves now. A fantastic perception, right? They're really fantastic. 1, 2, 3, coming into the plexus. Now those are preganglionic parasympathetic nerves. Parasympathetic. They are coming from the sacral part of the cord, S2, 3, 4. The lateral horn again. Right, okay? and they are here preganglionic. Now they don't, at that point, they go right through the plexus, and they're taken by the um, by the vessels towards the rectum, the muscle, blood vessels, and everything that's controlled by the autonomic. Whereby sympathetic preganglionic neurons, they synapse on postganglionic neurons here, and then they're taken to the target organs. But the parasympathetic now, they pass through their ganglia and not in here. The postganglionic neurons are not in here. The neural bodies, they are in the organ itself. So where I should have told you about, and Mr. Gardner that told you also about Hirschsprung disease, right? Hirschsprung disease, those ganglia, those postganglionic sympathetic neuronal bodies, they're absent when the plexus is in the bone. Okay? Right? Okay, so that's why you have probably the most common cause of large bowel obstruction in children. It's Hirschsprung disease. Right? Okay? Right? Similarly here, they are going to control the internal signal. Right? Okay? And the rectum. Right? Okay? And the muscular rectum. Okay? Right? Any questions before we have a few more minutes? But I want to just make certain that anything at all you want me to go over. Right? Anything else you want me to show you? Tomorrow, I'm going to do, I did the inner canal. I told you about inner fissures when I did the inner canal. I told you about hemorrhoids. I told you about inner atresia, perfect anus, all those things we went through already. Any questions at all you have? Everybody's hungry? All right, so
Can you show the
we have a few more minutes, but I just wanted to show you this because you don't get a chance too often to see the pudendal canal.
did you answer the question about what causes the hemorrhoids?
Hemorrhoids, okay, that's what causes the hemorrhoids. Sorry. Hemorrhoids really, some people seem to have a hereditary predilection for hemorrhoids, okay? Not that it's a gene, it's just that it runs in the family. Maybe that the families have the same dietary habits because most people, it's poor bowel function, right? Okay? And they have to strain to pass stool, and straining leads to dilatation of these vascular cushions, okay, that are present. Where the vascular cushions are, they are 3, 7, and 11 o'clock. Right? Okay? Every column has a terminal radical, but at 3, 7, 11 o'clock, we have the vascular cushions. Right? Okay? And then when they start prolapsing, they're like this. Right? Dr. I told you when I did the anal canal, I told you about the mucosal suspensory ligamental parts and the submucosal muscle, which is called tris muscle. That helps to prevent, right, hemorrhoidal prolapse of these anal cushions. Right? Okay. So, right.
And then someone wants to see the fascias.
Which fascia you want to see?
All theirs.
Fascia. All right. Let's go back to the first one. First image. I have some good sections here.
Then okay, as well.
All right, so you want to go back? No, not this one. So what I did here, guys, is that I had to open up. Right away, here's your rectal fossa. This is the inner canal here. So this will be the right issue rectal fossa you see here. Right, okay? Right around here. Right, okay? And with the issue rectal fossa. It's going to be here. So I really should tell you what the walls of the issue rectal fossa, right? Is that medially it's going to be here. It's like a little triangular space there where there's fat, right? Okay. And the medial wall is going to be levator ani and the sphincter externus. The lateral wall is hidden over here, right? Okay. You're not really seeing it too. It's the sphincter. It's the obturator entrance. Obturator entrance on the lateral wall. I'll show that to you tomorrow. Right, okay? And fat, this fat here is present in that. Right, okay? And have the support. So the rectum has a lot of supports. Right? We have Walder's fascia, we have the Vata Ani. That's the pelvic diaphragm I'm talking about there. Right? Then we have fascia denovilia. We have these fat pads here, right? Sometimes when somebody loses a lot of weight, right, like elderly people who are cachexic, elderly people we're talking about now, not somebody who died, right, and they don't have all this fat, right? Sometimes they get rectal prolapse. The rectal prolapse usually more than that, but that and sometimes that in a emaciated person can lead to rectal prolapse. So the fat pad that's present in here that helps to support the rectum also, right? Okay, but the Vata A is one of the main things. Fascia denovilia, the posterior wall, this fascia here, right? Holding the rectum right here, right? So this is the rectum here. That's the appreciable fascia of all that there. Remember that this here. Denovilia fascia anteriorly, right here, right here, right down, right here. Recto prostatic fascia, recto prostatic, right here, and this fascia here. When you don't want to breach it when you do rectal procedures because it separates poop and urine. Okay, water. Okay, all right. Anything else? So you happy, Ariel? You've seen Walder's and Denovilia? All right. Anybody else want to see anything else? All right. So let me ask a couple people questions. Ariel, that's Ariel. Okay, Ariel. Where are you from, Ariel? Are you from Jamaica? Trinidad. So you haven't been up to Jamaica yet, have you? Second year, and you haven't been in long. Yeah, I feel it for you guys, right? That you have not